Hello, students. Mr. Streb back again, picking up where we left off last time. What I am going over this week is the remainder of chapter 40, and then I will go into 41 as well. So we stopped on page 822 last week, and just to recap, we kind of stopped around the autonomic dysreflexia, talking about that neurological emergency that you have to treat in order to prevent any kind of hypertensive stroke. So we know one of the most important ways to reduce the cause is by preventing bladder and bowel distension. Make sure we're managing pain. Think about room temperature. Think about monitoring for early vital sign changes. We'll kind of get down there a little bit as we get into TBI more and just ICP in general. But that's kind of what. Go back and think about what autonomic dysreflexia is. You can go back and look at that again in the previous lecture. Then we kind of started getting down into spinal cord injuries themselves. We were there, but kind of how you fix it. So when we think about somebody with a spinal cord injury, we're talking about stabilizing the spine so we can prevent any kind of actual spinal cord damage, right? So usually they're going to be a fixed skeletal traction they're going to have on. It's going to be a halo traction. I'm sure y'all seen that halo fixator device. It looks like you wear a plastic vest that has these metal poles coming up. I'll show you in a minute, with a crown. And it's usually, worn from anywhere from, 2 to 3 to 4 months. It kind of depends on where you're at. But yeah, those screws are directly going to your skull, if you will, to keep your spine in alignment. Because there's a spinal fracture, right? There's some kind of fracture of the spinal column, and we're worried that we're going to cause some kind of actual spinal cord injury that we can't recover from. So here's your halo fixator right here. It's literally in your head. There's a lot you can go over in your books. We kind of done this, but I want you to think about a few things. I want you to understand what your job as a nurse is. So what are the action alerts? Go back and always think about your safety priorities as a nurse. This is on your patient. Look at this. What could possibly go wrong? What if they have some kind of airway compromise? What if there's an issue where you literally can't get oxygen in and out of the body? Unfortunately, sometimes we might have to remove this. So there has to be a special wrench. It is there. You need that wrench to loosen the vest in emergencies. Like if you have to do CPR, you have to do chest compressions, that wrench should be taped to the vest regardless where they're at. It goes with them everywhere, because if you're out at Walmart and this occurs, they might have to take the vest off in order to do compressions if the patient is dying. Monitor for any kinds of signs and symptoms for a possible infection, because we know the infection is going to increase pressure in the head as well. So we're talking about fevers, any kind of drainage from the pin sites. Make sure you report that immediately. All right. If I'm thinking about, once again, what is my job with a halo fixator, me as a patient, what am I going to teach the patient and their family? There's a lot. You can go through this. I just highlight some of the big things, like keeping a straw available to drink fluids, because they're unable to really flex and extend their neck the way they should. So, and we think about that flexion versus the extension of the neck itself. Cut things into bite-sized pieces. Once again, they have limited mobility throughout their entire, not just airway, but their oral passage into their stomach. So the start of the GI process here. Make sure you cut the things that are hard to swallow, that can be a choking hazard, into small pieces, a lot like a child. And I don't mean that in a negative way, just make sure you understand that, because chewing and swallowing and aspiration is a huge part of this. All right, a couple other things that we talk about in the book that I find important when you're really kind of diving into what spinal cord injury is. And we know spinal cord injury, what are we worried about? The same things we're always worried about. Perfusion, we're worried about mobilization. So can the patient get up and move around? One of the things we're going to give a patient who has a physical trauma, that causes a spinal cord injury, is a proton pump inhibitor to prevent distress ulcers. Typically, that's what people are going to be on. So I don't think it's going to be on any exams anytime soon, but I want you to understand what that looks like and why would these people need that. Always be looking for patients who have certain medications they're on and what we're kind of doing. So if you look at this, if you look at what we have going on here, certain medications your patient might be on. So think about a patient who has skeletal muscle problems, we're going to give them a muscle relaxer. If we take that muscle relaxer away too quickly, then we could cause our patient to have hallucinations and seizures. Just safety precautions. We're always worried about safety precautions, if you will. All right, so here are some of the things we can do. Managing the decreased mobility. Our patients are going to be laying around quite a bit more than they typically are. So we're going to worry about pressure injuries and think about that alteration, right? Why would they have pressure injuries? If they have sensation issues, so if you go back and look at the what the exemplars are for each chapter, they talk about mobility, they talk about sensory perception, right? These are what we're trying to prevent. So when we start thinking about what is the nurse's job, we have to figure out ways to reduce complications because of decreased mobility, pressure ulcers, things of that nature. We also have to think about pressure injuries, maybe not because of mobility, but because of sensory perception. If they can't feel that hotness or the pain, you know, on the backside of them or on their arm, they might lay there too long and cause some breakdown. So repositioning patients every couple of hours is super important. Make sure if they're in a chair that they reposition, you know how they push themselves up in the chair like this for as long as they can, but every hour or so they should be repositioning themselves if possible. Do the wheelchair pull-ups, things of that nature. There's a lot in your book, so you can go back and look at it. I'm not going to hit on everything. Sexuality is a major concern. These people are going to have a lot of intimacy concerns, so that psychosocial, so maybe getting them with a social worker or somebody who can help with that mental health piece is very, very important. That's the other parts is really the long-term effects of immobility are going to lead to pressure injuries. We have to think about fractures. If you're not doing weight-bearing exercises, osteoporosis is a huge problem. So our patients who aren't getting up and walking around, so if you have a lower spinal cord injury or any kind of spinal cord injury where you have paralysis or lack of mobility, we know those are likely to occur. And we know that these pressure injuries, when you start getting infections, osteomyelitis, septicemia, it really becomes problematic. So what are we going to teach our patients? Everything. Focus on nursing interventions. You have to. That's what we're going to do most. Think about mobility, pressure injury prevention, bowel and bladder training. A lot of times they don't have the sensation to pee and they can't get it out themselves. They can't urinate on their own. So we're going to have to teach about self-catheter, you know, what that looks like. Cathing 4, 5, 6, 7 times a day. It just depends on what your caregiver provides there. All right, here's some more nursing interventions. If we're talking about a patient who is immobile and they lack the weight-bearing exercises and we're worried about them getting infections like osteomyelitis and things of that nature, take measures to prevent osteoporosis. So think about calcium and vitamin D supplements. Avoid things like caffeine and cigarette smoking because they do hasten osteoporosis. Excessive exercise against resistance. We know that if you can help them do that, it slows bone loss. These are the kind of things that you can expect to see on ATI and NCLEX. They're not going to go away because your patient, when you walk into their room, you're going to have to think about meticulous skin care, repositioning, making sure that they know how to lift themselves. And then other things, constipation. If you're not moving, your motility is down. So we have to think about fluid intake, eating certain foods that are higher fiber diet, giving stool softeners as needed. There are just things that have to pop up in your mind. Do you have to go over all of these right now? Probably not, but I want you to definitely be aware of those. All right, so that's chapter 40. I'm going into chapter 41. There's a lot in this one because we're talking about all of the things that are left. So what are we talking about here? Your syllabus says we're going to talk about increased intracranial pressure on multiple pages. We're going to talk about traumatic brain injury. That, guess what? It goes in between all of these because a TBI will increase your intracranial pressure. It's not the only reason you would have ICP, but a traumatic brain injury is definitely something that we know will hasten and make worse and increase intracranial pressure. And then a craniotomy, we'll kind of hit on that too towards the very end there at 924 to 926. All right, so let's move on right down to 907. But before we get there, I'm going to stop where I always stop, right here. This is how you should read your book every single time. If you go to a chapter, why does this chapter matter? Because in this chapter, spinal cord injuries and TBIs are going to cause a perfusion issue and a cognition issue. How do we know that? Well, if we go down and think about it, the book tells you perfusion will be impacted by stroke, right? What is a stroke? A stroke is a lack of blood flow to your brain. It could be hemorrhagic, where you have a maybe a pressure builds up or a brain bleed and you bleed out. If the blood with the oxygen that's supposed to go to my brain tissue is just circulating inside the skull, lack of perfusion. If I don't have perfusion to my brain, if I have a traumatic brain injury, if I have some kind of damage to the brain tissue, if I have a lack of oxygen, a hemorrhagic stroke or an ischemic stroke, it doesn't really matter. They're both going to lead to what? A brain injury. So there we go. Cognition, the ability to recall and think and manage your personality and your impulses and your ability to kind of function on your own. Cognition is very much a problem. So if you're thinking, Mr. Streb, what's the most important part? This, perfusion and cognition. Mobility, if I have cognition problems, traumatic, sensory perception, these are things that we are going to have to deal with. Mobility, immobility, sensory, pain, infection, getting skin breakdown, the risk for falls. All of these are going to be priorities for us as nurses to really think about. All right, so keep that in mind as we start progressing. We're going down to 907 first, and you know I've already pre-read with you guys, so that's what I do before I ever get started. So when we get started, let's think about what ICP is and what we need to do. So ICP is increased intracranial pressure. If you think about the way your body is designed, your skull does not flex out or in. It does not move. It is very hard and is permanently there. When children are born, they have those sutures that allow the skull to open and close. That's why they have soft spots in babies. We no longer have that. So any change in the amount of fluid inside of our skull is going to increase intracranial pressure. And that pressure is going to start tamponade or squeezing the brain. As you put pressure on the brain, you decrease perfusion by blood flow. So that is really what we're talking about here. So think about what we're really looking at. We're looking at blood flow. So we're talking, go back to the top, ischemic, lack of blood flow. So when we're monitoring for ICP pressures, that's something that we have to do. A patient is most at risk for ICP being increased because of the edema after the first 72 hours of a stroke. So if we're thinking about a stroke patient, we really have to be on top of it. Neurological status every couple of hours for the first 2 to 3 days. That's where we have to be. The first signs and symptoms of increased intracranial pressure is a decline in level of consciousness. If you're not getting blood flow to your brain, we call that hypoxemia, right? Your brain is becoming hypoxic, the brain tissue itself. If it's not receiving what it needs, you're not going to have good cognition. It's no different than anybody else. Hold your breath long enough and you'll pass out. So decreased level of consciousness is your early sign. Aphasia, changes in speech, your inability to swallow, inability to talk and say things. Pupillary changes, we'll talk about that later on. We'll talk about what a blown pupil is, or fixed and dilated, things very much like that. Those are signs and symptoms that maybe something in your brain is going on. And it doesn't have to be necessarily a brain injury. It could just be ICP being too high. So think about what ICP is. Go back and look at these signs and symptoms. Cushing's triad. This is something we're going to talk about heavily later on. And Cushing's triad, to Mr. Streb, when I'm explaining it, I think about that as kind of neurogenic shock. It's not exactly the same, but if you think about shock, and we're going to go over shock in depth next week, okay? Or week 8, which is what we're in shortly. So in my next week's session, I'll go over shock, but I want you to start thinking about shock now. All shocks are pretty much the same. Shock is a hypoperfusion of the tissue. That's it. So whatever the cause of shock is still the same outcome. You're not perfusing the organs. If you're in hemorrhagic shock or hypovolemic shock, you don't have enough blood volume to perfuse the organs. If you're in cardiogenic shock, your heart's not working correctly enough to perfuse the organs, right? If you're in anaphylactic shock, you can't breathe, you have no airway, so you're not perfusing the organs. It's the same. Neurogenic shock is the same as well. You're not perfusing the organs. The big difference is all shocks, for the overwhelming majority of shocks, with the exception of neurogenic shock, they all present the same way. If I'm hypovolemic, I don't have enough blood volume, what's my blood pressure going to be? Low. I'm going to have hypotension. If I have low blood volume, cardiac output equals heart rate times stroke volume. If my volume is down, my heart rate goes up. So for most shocks, with the exclusion of neurogenic, will be hypotensive, tachycardic, and tachypnic, because you're trying to compensate. If you look here at Cushing's triad, a very late sign, it says severe hypertension, bradycardia, and widening pulse pressures. I'll talk about those later, but it's kind of the opposite. So with these neurogenic type patients, ICP, it is not uncommon to see Cushing's triad as one of our signs and symptoms of neurogenic shock, if you will. And then we'll talk about posturing. Decerebrate, where your body is completely out, your hands are beside your side, your body is functioning, right? You're kind of going hard as a board. The corticate would mean your arms come towards your core. The core, corticate, decerebrate. So those are late signs. When you see a patient with a head injury, I'm a trauma nurse, a level 1 trauma center, most of my career in the military for 24 years, and a lot of trauma. So you see these signs and symptoms when they come off the ER after an MVA or a motorcycle wreck. You see all of these things. It's very common to look at. Like I said here, the first sign of increased intracranial pressure, cognition changes. That's why we go in. The first thing we say is, "Hi, I'm Nurse Lewis. I'll be your nurse for today. Please tell me the date. Please tell me where you're located. Please tell me the president." You're looking for cognition always, because the first thing you're going to recognize is weird voices. My mother was this way when she would bleed. She had diverticulosis. I'd be on the phone with her and she'd be talking to me. I'm like, "Oh, mama, you're not perfusing your brain correctly." I could tell just by the way she couldn't get words together. She couldn't really hold on a conversation. She would be very, very, very forgetful. Lack of blood flow to the brain. That's all we're talking about here. We said perfusion. That's what strokes cause. That's what traumatic brain injuries cause. They cause a lack of perfusion to the functional organ, which in this case is the brain. So best practices. These are things you have to know, because when you walk into a patient's room, this is what you're responsible for. Elevate the head of the bed, right? To prevent certain things and also to improve perfusion. I promise as we get down here, I'll show you some more numbers, but never over elevate the bed either. It's got to be between like 30 and 45 degrees. We typically have these patients above 30 degrees, but less than 60. There's a reason for it. Maintain the head in a midline neutral position, especially when we start thinking about spinal cord injuries. Hyperoxygenation the patient before and after suctioning. We need to think about this, because when we think about ICP elevation for dilation of cerebral arteries, we know that we'll talk about hyperventilation as well. Hyperventilation in the first 24 hours can be problematic because of hypercapnia. We know that when your CO2 levels get too high, it causes vasoconstriction. So we'll talk about that as well. But I want you to be aware of that. When you're going to go in and suction, you want to hyperventilate first for sure. But make sure that you have suction equipment at the bedside, because these patients, if they need to be suctioned, what happens if their airway gets clogged? What happens to the pressure in their head? So provide airway management, prevent any kind of unnecessary suctioning or coughing, because all of that is going to increase intracranial pressure. Make sure you know what your job is, okay? I want to get, like I said, I won't get into a lot of stuff, but you know, ischemic strokes versus hemorrhagic strokes, we treat them kind of the same thing. What I want you to always be aware of is that your job is to look for your patient, is to be monitoring for any kind of issues, right? We are really thinking about our patient's blood pressure and how it relates to perfusion. Perfusion is the name of the game here, because ultimately, if we don't perfuse the brain, we cause brain damage. And now the patient is going to be dependent on folks for the rest of their life. We will get here and talk about arterial pressures and maps a little later on as we get down towards that Cushing's triad a little bit more, and I start talking about that widening pulse pressure. But for the time being, that was page 907 in your syllabus. So we're going to keep moving down, just like it told us to do here. There's a lot of stuff we can go in and look at, but we don't have to, because we've already looked at the syllabus, right? And the syllabus already told us what we can and can't do and what we should be looking at. All right, so I'll keep moving down just a bit. Just because I'm not covering it doesn't mean you shouldn't look at it. I mean, if we're thinking about a patient who's sitting in a chair and not moving all day, we have to think about venous thrombus prophylaxis, maybe on some kind of, if they have SCDs, you can put on their legs while they're sitting still doing nothing, right? Does that really help or not? Think about the medications, some kind of low molecular weight heparin. They're going to be put on something. I'm not getting into it. I just want you to be aware that those things exist. All right, so this is where we kind of pick up again with TBI. So if we're thinking about this exemplar, the cognition concept, right? That's what it talks about at the front of the book. I want you to start reading the book and thinking like a nurse. Traumatic brain injuries, cognition is going to have a problem with the way they're able to function and do their whole life. It puts them at risk for falls and wandering off and being injured, burning the house down, getting burnt on the stove. You name it. If you have a TBI, it depends on if it's mild or moderate or severe. It's really going to depend on what happens. Your book goes into great detail about the causes of a TBI. I don't think I'm as near as concerned, but I will hit a couple of them, right? Everything, when we think about TBI, I want you to think about the same stuff. It can be permanent or temporary, and it's going to lead to cognition, mobility, and sensory perception issues that we're concerned about. Why am I going to talk about any of the pathophysiology? Because it's important to understand the type of injuries, how these injuries are sustained. So a traumatic brain injury, a lot of time is caused, especially in the United States, by deceleration. Like you run into a tree in a car, you're riding a bicycle and you fall off at 40 miles an hour. You're skydiving and hit the ground. None of those things are how you're designed. So a lot of these things can cause a contusion, which is a bruise on your brain. It could be a laceration, which could be a torn vessel that might bleed. Those are the things that might happen. But an acceleration and a deceleration, these are typically what we're thinking about. Acceleration, you're driving in your car, right? Your head is going, you get hit from the rear end. Acceleration, your head gets hit the back. Imagine like you're in a car or an airplane and the airplane takes off at Mach speed. What happens to your head? As your head goes back. So acceleration injuries cause your head or your neck, right, to do what? To flex backwards. That flexing can cause a spinal cord injury. A deceleration, you're driving and you run into the car in front of you. As you decelerate, your head goes forward, you hyperextend your neck, you can also cause a spinal cord injury. I just want you to be aware of what a test might say. It might be like, hey, a patient's in the car, blah, blah, blah. Both of these cause your brain also to go forward and hit the front of your skull and the back of your skull. We call that a coup counter coup. Like anyway, we can talk about that later. It's not in your book, but it's a kind of injury where you could also have a brain injury on top of a spinal cord injury. So when a patient comes into your ER or you walk into their room in the med-surg floor, wherever you're at, first thing we're going to do is look at the patient and we're going to try to figure out what's going on with them. If you don't remember what the Glasgow-Coma scale is, make sure you go back into the previous chapter and look at it again. A Glasgow-Coma scale is a way of looking at our patient. It measures, do they respond to verbal? Are they able to move? Painful stimuli. A GCS or a Glasgow-Coma scale can range from a 3 to a 15. A dead person has a GCS of a 3. A person who is totally normal has a GCS of 15. In these categories, go back and look at it. What I want you to remember is the same thing. It lets us know kind of where they're at cognition-wise. Why do we care? Because what's the first thing that goes away when you can't, when you lose consciousness? Your ability to maintain muscle contractions, maintain your airway. So these patients with TBIs are often at risk for what? Airway compromise. So that's something to think about. So I think when as a trauma nurse, a GCS of less than 8, we typically say intubate. And we'll talk more about this in a minute, I promise. That's just a great thing to keep in your mind. A GCS less than 8, intubate, because we are truly worried about them maintaining their airway. A concussion, it can be something that can cause GCS changes, right? It's a very mild type of TBI. Think about somebody who falls and hits their head. You're a football player. Yeah, we know this. Military people, if you're in a Humvee and it gets blown up, you might not die, but you know the repercussions, the percussion blast, it causes a concussion as well. If you hit your head against the side of the Humvee when it flips over, like I said, you're a football player, head-to-head contact, it will cause a concussion, which is a traumatic injury to your brain. That's what it does. It's kind of like a bruise of your brain, right? It depends on how bad it is, but we typically think about impaired cognition, memory, thinking. I'm sure a lot of you have heard that when you get a concussion, you're not supposed to go to sleep, right? My mother told me that as a kid. I fell out of the car one time and rode down the road at like 8 years old. It explains a lot, doesn't it? And when I hit my head, she called the doctor. We didn't have insurance, so we didn't go to the doctor. She called him. He's like, just don't let them sleep for the first 24 hours. Why? What is the reason for that? It's not because I'm going to die in my sleep. I might, but it's the impaired cognition. How would you know if the earliest signs and symptoms, right, are cognition changes, the ability to think, memory, stuff like that? If I'm asleep, how will you know if I'm having cognition changes? So there's a lot going on there. Teach your patients also not allow your patients to engage in any kind of strenuous activity for at least 48 hours, because as we progress, a lot of times with these mild to moderate TBIs, it can take 2 to 3 days for your symptoms to really start showing up. So there's always a reason. Anything you heard from somebody was probably based in facts. It probably just got lost in translation. All right. Am I really going to talk to you about the pressure numbers and stuff? I don't know. If you don't know numbers, you don't know numbers. So a normal ICP is about 10 to 15 millimeters of mercury. As it starts to go up, a sustained ICP of over 20 is considered to cause brain damage, right? It's going to start ischemic changes in your brain. So it's important for you as a nurse to understand this kind of stuff. Avoid anything that worsens ICP. Empty the Foley catheter. What happens when your Foley gets, what happens when your bladder gets distended? It causes, remember from the last time, I'm not even going to say it, I'm going to make you go back and look at it again. What does a distended bladder cause? What does coughing cause? So we have to avoid coughing. We have to avoid deep breathing. We need to log roll our patient instead of sitting them up. Anything that causes that ICP to go up too high is going to cause, it can cause autonomic dysreflexia. It can cause more pressure in the brain and cause excessive bleeding. That's what we're talking about here. As ICP increases, right, cerebral perfusion decreases, leading to brain damage and ischemia, edema, you know, that's what we're talking about here. Increased ICP is the leading cause of death in head trauma in patients who actually make it to the hospital alive. So that's where I need you to focus. What is your job? I'll show you in the book where it talks about this a little more down there as well. All hematomas are potentially life-threatening. Why? Think about it. Bleeding inside the brain, it starts occupying space. There is only so much space inside your skull. It's got a little bit of fluid around it, and that's all that's supposed to be there. So as you start competing for space, the skull is not going to bulge out. The brain will be compressed. That tamponade will tamponade blood flow to it, and it will cause you to have ischemia to the brain. All right. I don't know how much you get into epidural hematoma, but to me, epidural hematoma is arterial bleeding. All right, as we start going down, we can look at that, but this is where we're getting at. Think about hemorrhage. If you have a stroke, if you have a hemorrhagic stroke where you have pressure, hypertension, it gets so bad that you pop an artery in your brain, that's what an epidural hematoma is typically. Arterial bleeding, you can already understand what that looks like. You have to notify the rapid response right away, because a patient who has an epidural hematoma, if they lose consciousness, that is a medical emergency. Because now the cognition, you don't lose that. You're going to have somebody come in there and probably do a burrow in their skull, maybe cut out a piece of the skull. That is something you and I as nurses are not going to do. So it's important to know when to hold them and know when to fold them. Sometimes you have to call for help. So like I said, that is a epidural hematoma, where you start to bleed inside the brain itself, and it causes that pressure, and it starts including blood flow here, and everything past that is an ischemic attack. A subdural hematoma, this is more of a venous bleed. Are we as worried? Never. It doesn't bleed as fast. So an acute subdural hematoma, typically 48 hours after impact, right? It can be 48 hours to 2 weeks. It can be even up to months. So it's important for at least the first 48 hours that we're trying to avoid any kind of strenuous pressure or excess coughing, sitting up too high, you're supposed to take it easy. So we're going to look for worsening headaches. We're going to look for any kind of acute confusion and seizures. These are things that you need to be on the lookout for, because these are typical signs of somebody who's having a brain bleed. You can go back and look at the rest of them. Just be aware. You're not going to know yourself. It's just presentation and timing. Hydrocephalus, this is just increased fluid, CSF in your brain. I won't get into any more than that, but I want you to be aware, if you hear that term hydrocephalus, we're just talking about CSF building inside the skull again, and it's competing for space. It's going to lead to increased intracranial pressure, and you're going to recognize that by all the other signs and symptoms of ICP. I mentioned this earlier. What's the most common cause of TBI in the US? It's a fall or an NBA. So who's at greatest risk for TBIs? It would depend on what the question said. Young people who drive fast and ride motorcycles and things like that, TBIs. Unrestrained children, TBIs. Older people over the age of 60, and I'll show you some statistics in a little while. They are at increased risk for falls as well. So it would depend on the question. You're going to have to use your deductioning skills to figure out which patient is at greatest risk, depending on the number of choices that are there. We know that women, less likely. We know that men, especially if you play sports, if you're in the military, yeah, you're a lot more likely to do stupid stuff. More so than women. Women tend to be a little less careless, if you will. I guess probably because they get pregnant and have children. Nature versus nurture. I'm sure there's a reason there. We won't get into it. But I just want you to be aware of these kind of things, because what type of patients, think about teaching, think about promoting helmet use on any kind of thing. Mr. Streb's bad about this. I roller skated the other day and didn't wear a helmet. I probably should more often. Motorcycle riding, we won't even get into that. I'm a trauma nurse, but these are the things we have to talk about. Preventing falls, think about a safe environment, especially in the older population. Be aware of environmental factors like loose rugs, inadequate lighting. Y'all, these always show up. Why do they show up? Because these are the things that we can prevent. We can't do anything to fix the TBI. That's not our job. We can't do anything to fix the ICP. I mean, the physician is going to prescribe certain things. There are things we're going to do within our collaborative care team for our patient, but a lot of that is somebody else's responsibility. We need to know what our job is. So just go back and think about cognition, amnesia, loss of memory. These things are very, very important for you to know. You can go here and look about the older population. Highest incident of brain injury of all groups, right? Second highest. Why? Because they fall. Falls and motor vehicle crashes. Most common. I just want you to be aware, not because it's going to be on your exam per se, but you don't ever know what they're going to put in the stem of the question. It could be a patient who fell or an age group. It's your responsibility as a nurse when you walk into a patient's room to look at them based on their age, their prior history, their presenting signs and symptoms, what they tell you. That assessment data is going to make your nursing brain say, oh my goodness, you're at risk for falls. I got to put you on fall risk and red socks and a band and blah, blah, blah. That's what we do. That's not just made up stuff that happens. That's your job as a nurse. It's not memorizing the book and trying to be the smartest person who sounds the smartest. It's the ability to deduct what's going on. All right. Like I said, make sure you're assessing for signs and symptoms of ICP. Hypotension, it could be hypertension, hypoxemia, hypercapnia, oh my goodness, I can't speak today. Having your CO2 levels, you have hypercarbia, you have CO2 levels greater than 40 to 45, right? We know when you have increased CO2, when you have increased, that increased CO2 level is going to cause your body sometimes to release some catecholamines. We know that it causes vasoconstriction, which can also cause problems. So it's important for you to understand all of this and to be on the lookout. We have to look at ABGs. We have to look at our partial CO2 levels and see where they're at. If we're not, it could be a problematic event. So it's important for you to understand. Injuries of the brain may cause major life-threatening problems. Like I said, think about breathing patterns. Think about Cheyne-Stokes respirations in an unconscious patient. What does that look like? What are we worried about? We still have to go back up here and think about CO2 levels as well, right? Just things for you to know. All right, so if we're thinking about mild TBI, if I have a mild traumatic brain injury, typically a loss of memory for the events immediately before or after, that is something that we typically see in a mild traumatic brain injury. So patients might have amnesia about what happened. Like they can remember everything up to it and everything after, but like that short period of time before and after, that whole period is gone. It's kind of an interesting conundrum. So that's typical of a mild traumatic brain injury. They typically resolve within 72 hours. Like if you get a concussion or something, you might not remember everything right up to it. There's more, and I'll keep talking about it, but amnesia. I keep saying it, y'all, because I see this on every NCLEX question I've ever seen, every ATI, because what are you as a nurse going to notice first? Cognitive changes, amnesia, drowsiness. This is what we find. We are not going to see a lot of anything else. We might see some stuff with blood pressure, but with a mild trauma, a mild TBI is typically things that we can see cognition-wise. So be on the lookout. I'm going to go back to the Cushing's triad again, because that's what I wanted to say with vital signs. Vital signs are a huge, huge tool that every healthcare provider, nurses, doctors, techs, it doesn't matter what your role in the healthcare is, you are responsible for understanding assessment data, what it means, what the likely causes are, and what you can do to change or better that. So if we're thinking about Cushing's triad, I want you to understand what we're talking about. Classic signs, but very late, of ICP being too high, right? We're talking about that severe hypertension, a widening pulse pressure, meaning between your systolic and your diastolic levels. When we talk about pulse pressures in general, this is not on your exam, but I put this over here. Normal values, when you think about your systolic and diastolic blood values, 80, 120 over 80, right? So you think about your typical map there, your mean arterial pressure, you think about your pulse pressures, we're talking about like a 40 there. Between 80 and 20 is about 40. We talk about a narrow, it's less than 25% of systolic blood pressure, but a widened pulse pressure is greater than 100 millimeters of mercury between systolic and diastolic. So let's say it's at 40 diastolic and you're at 200 systolic. There is a huge widening pulse pressure. So we think about perfusion once again, because of the pressure. If the pressure is too high, pressure precludes what? Blood flow into the organs itself. Hypertension will always cause a lack of blood flow to your organs. That's exactly what the cause of kidney failure is most of the time. That's why diabetics can't feel their feet. It's because of pressure. It's because of those microvascular changes and things like that. So that's what we're trying to get you to understand. Everything is going back to some kind of exemplar, if you will. So make sure you're paying attention to these things. You have to be the person understanding this. So Cushing's triad, what does it look like? Glasgow Coma scale, I've already mentioned this, less than 8 intubate. That's cool for initial, but a change in 2 points is considered clinically important. So if you have a patient who has a 13 on their GCS when they first get there, and now it's down to 11, y'all, that is an emergency. We should probably get our rapid response out there somewhere very quickly, because why? There's nothing you and I can do about it. So early indicators of changes in the level of consciousness, restlessness, irritability, disorientation. Report any of these signs and symptoms immediately to rapid response, because they will deteriorate fast. Time is tissue. The longer you hesitate, the more time you waste, the more brain tissue you are ruining, and the less effective your patient's life is going to be. Their ADLs are going to go down, and their level of cognition and everything decreases when you don't recognize the early signs and symptoms. Y'all, I can't stress that enough. It is your responsibility to be looking at your patient. That's why you have to delegate more things to your techs and your LVNs and your CNAs, so you can literally be in the room monitoring your patient and doing what your job is. All right, check pupils. Pupils are big. Y'all took 242 and 170 or something. You've taken some kind of pre-class where you've gotten into the basics. When you check pupils, you're looking for a reason. You have to document pupil size, shape, reactivity. Remember that PERLA thing that we always do and nobody understands why we're doing it? Well, now you're about to find out, because when you're in ICU patients, it is super important. Pupillary changes will let you know based on the area of the brain and what was damaged. So pinpoint, non-responsive pupils. I'm talking about their pinpoint. They're very small, and you shine light in them. They don't constrict and dilate anymore. They don't dilate and constrict. That's some kind of brainstem dysfunction, probably around the pons. Do I care where it's located exactly? Not necessarily, but I want you to understand that pinpoint non-responsive pupils is indicative of brainstem dysfunction, basilar skull fracture, something like that. Basilar skull fracture, some kind of spinal cord injury. It could be really high up. It could be a brain damage back there. like a basilar skull fracture or something of that nature, right? Asymmetric meaning one is dilated and one is constricted. That could be a herniation of the brain. Not that you need to know that specifically, but I just want you to be aware. Pupils that are fixed, that are non-reactive, that are dilated. A blown pupil, you probably heard that, they're just blown. It's a very poor prognostic sign. If you have fixed, non-reactive, blown pupils like this, right? That is usually indicative of death. They probably have a really severe brain injury. Patients with this problem, yeah, it's not good. All right, check movement. Think about bilateral. Check left and right. Think about a brain injury. It's very similar to a stroke. A stroke will lead to a brain injury, right? Think about a traumatic brain injury. If you get hit in the head and you get a hemorrhagic stroke, is that not a traumatic brain injury? The answer is yes. So don't try to think any more than that. They all lead to the same thing. So think about bilateral motor responses. If you have more strength on your right side and less on your left side, you probably have a left-sided brain injury. That's just the way it works. It's contralateral, like it says here. Ataxia, pardon me, decreased or increased muscle tone or weakness. You have to think about that. The absence of any kind of tone or movement could be very indicative of a spinal cord injury. You start seeing how all of these go together. You don't talk about TBIs and ICP and stroke and spinal cord injuries without talking about them all together, because they're kind of one and the same. They look very, very similar if you're not paying attention. All right, signs and symptoms you might see. Definitely, you can think about doing what's called a halo sign, where you're checking for cerebral spinal fluid. If you think about somebody with a basilar skull fracture, literally they fracture the bottom of their skull. So think inside of their brain housing group, there is a fracture of the basilar skull itself. When that happens, you start releasing CSF drainage out of your nose, rhinorrhea, out of your ears, right? Otic. So it's going to come out of your nose and your ears. How do you know it's CSF? You can do a blood sugar on it. You can test that for glucose, right? Suspicious ear and nose fluid can be analyzed right here. I'm just going to highlight it for you. Through glucose and electrolyte content, you can kind of see what it is. You can try to find out what's going on. A lot of what we do is CSF placed on a white absorbent paper or linen can distinguish from other fluids. So like a halo sign, a clear or yellow ring surrounding a spot of blood would be a halo sign. So you would take like a 4x4 and you would fold it up and you would take the corner and dip it into the blood itself and then open it up. If it's just blood, there won't be a clear yellow ring around it, because that's what CSF is. That's what we're looking for. A couple other signs, a raccoon eyes is just meaning that when you get a basilar skull fracture, you might see bruising underneath the eyes. You might also see something called battle signs, where you have bruising, hematoma back here under your ears as well. And we call that battle signs. Just things to keep in mind, okay? I must stop right here and pause just for a second and go back to analyze the priority collaborative problems for patients with TBIs, cerebral tissue perfusion, cognition, sensory perception, mobility. Every intervention we are going to do for this patient will revolve around the problems. That's what nursing is. So when you start understanding how we approach patient care, and you understand that the expected outcomes is that the patient will maintain what? Adequate cerebral perfusion with no evidence of further brain injury or ICP going up. That is everything we're going to do as nursing. So when you're answering nursing questions on your 260 or whatever exam for whatever this is going to be over, think about that. What is your priority? Always the same, y'all. Maintain patient airway, breathing, circulation. They die without it. So vital signs every 1 to 2 hours, because it's important for us to see if there's a change. Time is tissue. We need to make sure that we are doing EKGs and stuff sometimes, because any kind of stimulation of the autonomic nervous system or an increase in the level of circulating catecholamines. I keep talking about that. What is catecholamines? Epi, right? Epinephrine, adrenaline. What's that cause? Think about if somebody's chasing you, your heart rate goes up, you get some vasoconstriction in certain areas, you increase blood flow to the parts that need it, like your brain. Is there any reason at all we want to increase blood flow to your brain if we're having a bleed already? The answer, probably not so much on that, but we do want to think about perfusion. I get it. It gets a little bit tricky sometimes, but I want you to be aware of why we're doing the 1 to 2 hour vital signs. I don't want you to memorize. I want you to understand. Fever. When you think about a patient, think about that autonomic dysreflexia. I think about how the body systems kind of get messed up. One of the big things we think about when you have a patient with brain injury, what happens to any kind of injury? Blood flows to that site. That is why we have increased intracranial pressure. It's not because we're just leaking CSF out of our nose. That helps with ICP. It's the influx of what? Your immune response. As blood gets there, as they get there and the macrophage get there and they start trying to eat the dead blood cells and they start trying to eat dead tissue, it causes the inflammatory response. So that's what we're looking at. We think about blood. We think about the generalized inflammation. That is going to cause swelling, but it's also going to cause fever, right? So a patient with TBI might have fever. Fever from any cause associated with is associated with higher death rates, morbidity, and mortality. So with these patients with TBI, we're going to do something called therapeutic hypothermia. We are going to decrease their body temperature and in an attempt to save what? Tissue. That's it, y'all. Time is tissue. We do this with all kinds of patients. If you come into my trauma center and you have a stroke, you come into my trauma center and you have MI, a level 1, whatever, where we're at the ER, sometimes even with somebody who had a myocardial infarction, when they return to ROSC, we induced hypothermia, because if we can decrease your metabolic rate, that's what we're doing, right? If we keep your temperature down, if we rapidly cool the patient's core temperature between 89 degrees and 93.2 for the first 24 to 48 hours, we drastically decrease ischemic tissue loss. The amount of blood and oxygen needed for the brain to function goes down intensely. Same thing, if I do it after a heart attack, it decreases. It says right here, the rationale for hypothermia reduces metabolism. That's it, right? It really helps control the secondary injuries and making a worse TBI, if you will. Another thing we're going to do is we're going to look for end-tidal carbon dioxide. It's one of the measurements we do, especially when we intubate folks, right? It helps us guide our mechanical ventilation therapy. So when we are thinking about patients and their carbon dioxide levels, we have to be very cognizant of that. So if we're going to go through and suction somebody, hyperventilation for the intubated patient during the first 24 hours after brain injury is something we have to think about. So ABGs, all that. So hyperventilation for the intubated patient during the first 24 hours is usually avoided. Why? It can produce ischemia by causing cerebral vasoconstriction. And I talked about this earlier. Carbon dioxide levels, and carbon dioxide is a potent vasodilator. It can contribute to increased ICP. What is ICP? Pressure. If you increase vasodilation, it's going to let more fluid go in to your brain, right? It's kind of cool to think about, unless it's you or your patient. I just want you to know that. All right, so here are some things I want you to really pay attention to. Position the TBI patient to avoid, I've already said this, extreme flexion of the neck or extension of the neck, right? How do we do that? Maintain midline, neutral position, log roll your patient to avoid any kind of hip flexion. Keep the head of the bed elevated at least 30 degrees, because if you lay flat, all the blood gets there. 30 degrees, pretty normal. If you go too high, now we're having a problem perfusion again. So it's still lack of perfusion. So 30 to 45 is typically where they like to keep the patient, but less than 60 is what the other part of your book says as well. So, or at least the literature I've read has. So I kind of keep that in my mind there. We want to prevent aspiration as well. If they have a neck injury, they have a TBI, a lot of times they go hand in hand. So these are things that you as a nurse have to be aware of. NCLEX is going to ask you these things because this is what you have direct control over. All right. If you want to know if somebody's dead or not, there are 4 classic prerequisites to establish brain death. Do we do this ourselves? No. But coma, you have to be at the normal body temperature. You're not dead until you're warm and dead. That is a true fact, especially when we get into like trauma. If you think about somebody with hypothermia, you can't be pronounced dead unless you're warm and dead, because hypothermia can cause your body to slow down and you might not be dead if you're cold enough. Normal systolic blood pressure, if it's less than 100, are you really perfusing your brain? How can we tell if you're dead or not? Brain dead anyway. And then some kind of neurological exam by somebody other than us, I'm sure. All right, So what are the drug therapies? Mannitol. Mannitol is what they use a lot. It's an osmotic diuretic. It really is what you use to treat that cerebral edema. It pulls water out of the extracellular space in the brain and reduces some of that pressure. There's a lot of research on that. They don't know exactly if that's true. I don't know. For now, and for your test and for the books, we know that mannitol is always something we use. But when you give mannitol, mannitol has little crystals in it. Mannitol is better given through IV bolus as opposed to like a drip over an amount of time. Either way, if you give it IV or bolus, you will need to use a filtered needle to eliminate those microscopic crystals or some kind of IV tubing. I'm telling you this because you will work with patients and mannitol will be ordered. And if you're not using these filtered needles, you might kill your patient. Literally, you could cause an embolism. And we know what that causes. It could cause somebody to stroke out. It could cause somebody to have a heart attack or to have a PE. So we don't want to do that. Make sure you just understand that. Those are the safety things I'm going to say about mannitol with you. Sometimes they'll use other stuff to reduce the rebound effects of mannitol, but I don't think we really get into that too much. So what are we doing down here again? We're talking about interventions, and interventions are always going to focus on what? The exemplars. Cognition is a huge one. It is what it is, y'all. So we know that brain injury survivors usually have altered cognition, memory, impaired judgment, reasoning ability. They're more sporadic. They can walk out in traffic, more likely to drink excessively and take risk-taking activities. Y'all is problematic. So large lesions, think about interventions. Your patient might experience what? What kind of signs and symptoms? We're thinking about sensory perception. To what kind of stuff? They might have sensory perception loss to pain, temperature, touch. Think about the things you really have to be aware of. Are they giving the appropriate response to environmental stimuli? They touch something hot. Do they move their hand back or do they keep touching it? If they're testing bath water and it's too hot, do they burn themselves? Do they drink coffee? Their coffee's too hot. These are things that we have to talk about with our patients. I don't know if they'll be on your exams or not, but they'll be in your rooms in front of you. I'm trying to help you figure out if you can think this way as a nurse. When you get to nursing exams, the questions won't be that hard because you'll know what your job is. Disoriented, short-term memory losses. Always introduce yourself first. Explain things very shortly. Do it all the time immediately before you do it. Just because you explained it 2 hours ago doesn't mean you don't have to explain it again. Keep reorienting. These are all the same things. It doesn't matter what the cause of cognition or sensory perception is. If you lost it, you lost it. That's what I'm trying to get you guys to recognize is as long as you know what your job is as a nurse, you don't have to worry about memorizing everything for every disease. They all present kind of the same way. All right. So for a TBI, there's a few things I want you to be aware of. Think about a concussion. I'm not trying to put you asleep because what I want to do is make sure I can determine if you're having any kind of cognitive changes. So for mild TBIs, we give acetaminophen only. We avoid sedatives and opioids and stuff like that because we don't want them to fall asleep until we can judge and make sure that they're not having cognition changes. That might be the only signs and symptoms you have. So just be aware of what your job is. Look for signs and symptoms of worsening ICP or anything else. Right here at all this, seizures, headaches, unequal, you get this, right? This should be very obvious. If it's not, then it should be obvious to you that you have to go back and read and do some more work. The things I talk about need to come off your brain like this. If they don't, it's probably because you don't understand the material enough and you're going to have to really dig into it deeply and understand what it is your job is. So moderate to severe TBIs, what are we talking about? A little more problematic, more brain involved, longer ischemic times. So changes in personality and behavior, very common. Like I was just talking to my neighbor the other day, and her sister had this problem where she was trying to walk into the house and she's trying to pull the garage open versus the front door because that's where she thought she needed to go in. Very small things. This is the type of person who could walk down the wrong side of the road and walk out in traffic. It is very important that we think about safety, safety, safety. Evaluation. Are we maintaining cerebral tissue perfusion? Learn to adapt to altered mobility and sensory changes, and has minimal alterations in cognition or understands how to compensate for cognition changes. we're always trying to prevent injuries. We're trying to promote safety, and we're trying to make sure that when our patient leaves, that they receive the patient-centered quality care they deserve in order to go home and not, have worse outcomes and return to the hospital unneeded. All right, that is all we talk about on this chapter. You can go down and look at the rest of it. I'm sorry, not in this chapter. On the first part there, if we go back to the top, and let me just show you where we're at, that's page 924. Your syllabus says we need to stop. So 924 to 926 is where we're going to go next. We did TBI. So the last part is 924 to 926. Let me get all the way down here to this last part. I'm going to kind of go through that. All righty. So when we talk about craniotomy, I still go up just a little bit more, and I start getting into a few things. I know we're not talking about diabetes insipidus all that much. That's probably for a different group, but diabetes insipidus following a craniotomy with elevated sodium levels. What am I talking about? I'm going to get there for you. I'm going to start first. If you think about any kind of head injury, you think about that buildup of pressure. What are we looking for? Why? Y'all can go right here. You can look at all of this. Assess neurological assessments in the first few hours. It don't matter what we're talking about. All of this applies. Report immediate changes in neurological deficits, decreased level of consciousness, motor weakness, paralysis, aphasia, pupillary changes, anything at all, y'all. Anything at all is going to be a very good indicator that something's going on with your patient, right? So as the pressure starts building in my skull, I have a pituitary gland that sits in the middle of my skull housing group right there, right? It's by my brain. As that pressure builds, it could put pressure on there and include blood flow to my pituitary gland. It can cause pressure on there, exciting the anterior or the posterior pituitary gland. And we know that the posterior pituitary gland is responsible for the direct release of SIADH. So regardless of the setting, it doesn't matter what's going on. Think about eyes and nose. If the patient has a head trauma, think about eyes and nose. Diabetes insipidus and SIADH is what we're going to talk about here. So think about a patient. They might be on fluid restrictions. If there's any pituitary involvement, if they have to have surgery, think about a patient who comes back from surgery. They too are a patient who might be what? ICP patients. It doesn't matter what the cause is. It could be a trauma. It could be a freaking surgery. It could be a tumor that bursts, whatever the case may be. Anything that causes that pressure to go up very well might lead to SIADH or diabetes insipidus. It really depends on the patient, what's going on here. But SIADH is what we talk about here. What are we going to do? Keep the patient flat. So if they have a problem, craniotomy is what we're going to go into. So what is a craniotomy? So a craniotomy, let's go back and look at that real quick. I just want to kind of highlight it and say, a surgical incision into the cranium to access the brain. That's what a craniotomy is. They're literally cutting through your skull to get to the brain. They can remove a tumor. They can go in there and try to fix something. It could be a surgical cure. I don't know. They are cutting your brain open, and now they're going to cause what? Inflammation. They're going to cause an influx of fluid, and blood is going to rush that direction. It will cause ICP. So keep the patient, right, who had a craniotomy flat or at 10 degrees, depending on the primary. This is different than other ICP. We're saying with these people, they need to be flat or 10 degrees for at least the first couple of hours, up to, just depends on what the doctor says. I'm not going to get into the mix there. You can go back here and look if you'd like, but I really want you to be paying attention to what a patient looks like after a craniotomy. Position the patient in the sideline, alternating the sideline for 2 hours for the first 24 hours. We're trying to get them off their back. We want to make sure that there's no pressure. We're not building anything that increases ICP. Y'all, this is the same thing always. NPO, until they're awake and alert. I always say the same thing. You never put anything in anybody's mouth until they can consent. Don't give them fluids. Don't give them medications, nothing until they can say yes and they can swallow. You never put anything in their mouth ever. Think about drainage. I don't think we get in that a lot, but just pay attention. After a craniotomy, monitor the patient's dressing because we're looking for any kind of drainage. Anything greater than 50 mLs in 8 hours is an emergency, and the doctor should be notified so they can come in and fix it. It will probably see some ICP changes as well. Make sure you're looking for both of those. All right. So as we're thinking about our patient, as we're thinking about the patient who has a craniotomy, we're going to do all these different lab values. We're going to check for just a lot of different things. Osmolality. We're going to look for coagulation studies. Don't forget, like I said, electrolyte levels. Why? Because we're going to impact the pituitary gland, and the pituitary gland messes with everything, your ability to maintain urine, get it out, keep it in, whatever. So hyponatremia may also occur as a result of fluid volume overload. If I have SIDH, what am I doing? Inappropriate amounts of antidiuretic hormone, meaning I'm not peeing at all. So I am going to be in fluid volume overload. Hence why you would have a restriction of 1,500 mLs of fluid in a patient after a craniotomy, right? So, and then, give me 1 second. All right, so just keep that in mind. That's what I'm trying to get y'all to understand. If you understand how the body works and you understand that SIDH might be something there, then there's a problem with that, right? It's kind of neat. Steroid administration. Why would you be hyponatremic as well? We can get into that. We think about your adrenal glands, that salt, sugar, sex hormones, and how they work as well. We'll get into that later on. Hypokalemia. So you think about potassium. That might be something as well, because we're talking about electrolyte imbalances, so we have to worry about that. Hypernatremia could be caused by meningitis or dehydration or diabetes insipidus. A patient very well could have diabetes insipidus following a craniotomy also, and they might have elevated sodium levels because diabetes insipidus means you're peeing a lot, right? And if I pee a lot, what happens there? If you pee out too much, you become dilutional or whatever. So just, I want you to really be paying attention to your patients. Hypernatremia. What do we mean by hypernatremia? Did their sodium levels go up? No. Diabetes insipidus has insensible fluid loss, so they're going to be in fluid volume deficit. And when you're in fluid volume deficit, it causes everything to be more concentrated, including your sodium and things of that nature, or potassium. So we have to be very cognizant of these type of patients and what we're on the lookout for. All right, that really was the last thing we're going to say there. So if you have any questions, make sure you go through these. You can book in now. I have individual sessions that you can book into, group sessions that you can go and look at, and I'll be more than happy to answer any questions you have. All right, hope you have a great day.